Hello all, welcome back. Today we'll be continuing with neonatology. We have seen what is Apgar score. Just for recalling, Apgar score is appearance, pulse, grimace or reflex irritability, activity and respiration, given a 0, 1, 2 score. Appearance, if it is fully cyanotic baby, it's 0 score. Pink body with blue extremities, 1 point. Fully pink body, 2 points. Pulse, no pulse, less than 100, more than 100. Grimace, floppy baby, minimal response on stimulation, prompt response with sneezing, crying, or pulling away. That is 2 score. No movement or flaccid and floppy baby, that is 0 point. Flexed arms and legs, 1 point. Active movement is 2 points. Respiration, no breathing, 0 point. Irregular breathing, 1 point. Vigorous and strong cry is 2 points. We also have Vellard score for a preterm baby to find if they have the correct gestational maturity. Okay, now we'll come to Downs, Edward, and Patau. So Downs, Edward, and Patau. So we have 13, 18, and 21. There is an extra copy of any of this chromosome. If it is 13, it's called Patau. If it's 18, it's called Edward. And if it's 21, it's called Downs. Okay. So trisomy 18 is Edward. There is low birth weight, prominent occiput, small mouth and chin. There is short sternum, overlapping fingers. So this is usually the key given in the question: overlapping fingers and rocker bottom feet. Rocker bottom feet. Cardiac and renal malformations. This is the overlapping of fingers seen in Edward. Then in Patau, which is trisomy 13, again structural defects of brain. There can be scalp defects, microphthalmia. Okay, so this is usually coming in question. Cleft lip and palate, polydactyly, cardiac and renal malformations. Okay, again coming to Edwards and Patau. Patau, that is 13, intellectual disability, microphthalmia, microcephaly, cleft lip and palate, punched out scalp lesions, polydactyly, and omphaloceal. Polydactyly. In Edward, it is a closed over finger. Here it is polydactyly, associated with congenital heart disease. Death usually within the 1 year of birth in both Edward and Patau. Edward is trisomy 18, again intellectual disability, rocker bottom feet, lower set ears, micrognathia, clenched hands with overlapping of index finger over third finger and pinky over the fourth finger, and a prominent occiput. Okay, they may have horseshoe kidney also seen in Turner syndrome. Again, I've added more slides so that the terms will get fixed. Okay, clenched fist, diaphragmatic hernia can be there. There is rocker bottom feet. There is horseshoe kidney also with Turner. You can see that. And in a quadruple test, all of this is reduced. In Downs, what happens? In Downs, 2 of them are increased. What are increased in Downs? You have raised inhibin and raised beta HCG. The others are decreased in Downs also. Okay, AFP is decreased in Downs. So Down syndrome, it is trisomy of 21, and the most important cause is a meiotic non-disjunction. That is the term you have to remember. What happens in meiosis? The pair of the chromosomes get separated. Now there is there is some failure, something happening during that meiotic process, that is called meiotic non-disjunction. That is the most common cause in Downs. Okay, so the karyotype is 47XX with an extra 21, or 47XY with an extra 21. And there is early onset Alzheimer's disease. There is increased risk of AML and ALL. Okay, and the risk increases with increasing maternal age. Usually they are of short stature. There is hypothyroidism, hearing loss, recurrent otitis media. Heart defects, it is mainly atrioventricular septal defects. There is a single palmar crease there is an upslanting of the eye, okay, and there is diodal atresia, annular pancreas, okay, and there is this sandal gap. This is called the sandal gap, and there is simian crease or the palmar crease. Single crease is called the simian crease. There can be clinodactyly or a brachydactyly. These are different terms. Mainly, you have to remember they have a short stature, epicanthal fold, upslanting of eyes. They have ventricular septal defects, diodal atresia, and granular pancreas. They can have a saddle gap or a palmar crease, and they have early onset Alzheimer's and increased risk of AML and ALL. And the term for the problem with their uh, trisomy is meiotic non-disjunction. Downs is associated with atlantoaxial instability, duodenal atresia, Hirschsprung disease also. Okay, Hirschsprung disease, congenital heart disease. Mainly, it is the AV canal defect. Okay, and there can be other things like ASD, VSD, PDA. Okay, there is also increased risk of ALL, hypothyroidism, and early onset Alzheimer's. Okay, these are all you have to remember. Hirschsprung disease, duodenal atresia, they all can be there. Also, annular pancreas. Now, coming to neonatal sepsis. Neonatal sepsis, the most common causes are pneumonia and meningitis, and the most common organism are group B streptococci, E. coli, Staph aureus, or Listeria. Listeria is also seen in immunocompromised and elderly. Diagnostic test is blood culture, urine culture, chest X-ray. So if there is any indication, child coming with the fever, jaundice, mainly direct bilirubin, you have to work up for sepsis. You have to take a urine culture, blood culture, any signs of meningitis. You have to take up the CSF and culture, chest X-ray. The treatment, empirical treatment is ampicillin and gentamicin. A word on neonatal conjunctivitis. So neonatal conjunctivitis can be chemical conjunctivitis, or it can be the bacterial conjunctivitis or viral conjunctivitis. Chemical conjunctivitis is mainly by the silver nitrate drops. Now it is not common because we are using erythromycin drops. In day 1 to 3, it is mainly gonococcal. Okay, day 1 to 3 chemical, but now it is uncommon. Day 3 to 5, it is bilateral purulent, and they can also cause corneal ulceration, mainly by the gonococcal. We treat it with topical erythromycin. Okay, day 7 to 14, it is mainly chlamydial, and you have to give oral erythromycin because the topical may not be effective. Okay, ocular infections in the neonatal period. Chlamydia trachomatis in the 1 to 2 weeks, mainly with the oral erythromycin you have to treat. Neisseria gonorrhea in the first 1 week. Okay, it is more severe than the chlamydial conjunctivitis. Herpes virus also can cause conjunctivitis within the first 2 weeks of birth. There is watery serosanguinous eye discharge with vesicular eruptions. You can treat with acyclovir. So for this conjunctivitis, the empirical treatment can be started before the culture results are known. For chlamydia, you give topical also with the systemic oral erythromycin, because topical alone cannot be sufficient. For gonococcal, you can give IV or IM third generation cephalosporin. Okay, and for HSV, you can give 14 to 21 days of systemic acyclovir or a topical agent along with the topical agent such as vidarabin. Okay, acyclovir and vidarabin for 14 to 21 days. And for gonococcal, which is more severe, there can be corneal ulceration and resultant scarring within 24 to 48 hours. So you have to start in treatment. What is transient tachypnea of uh, newborn? It's a transient event, just like the name. It is due to pulmonary retention of the amniotic fluid. In the X-ray, you can see that there is interstitial fluid. Okay. Now, what is ARDS? That is acute respiratory distress syndrome, and there is a score for severity of the respiratory distress, which is called the Silverman-Anderson score. You have studied the EPGAR score. Now, this is a Silverman and Terson for the respiratory distress syndrome. In that, you are looking at the upper chest retraction, lower chest retraction, xiphoid retraction, nasal flaring, and grunting. Okay. So, if there is upper chest retraction, which is called the lag on inspiration, okay, or in severe cases, it is like a seesaw appearance. So, if there is lag on inspiration, it's 1 point. If it is seesaw, it is 2 point. Lower chest retraction, if it is just visible, 1 point. Mark it, 2 point. Again for xiphoid, it is just visible and mark it. Nasal flaring, minimal flaring, 1 point. Mark it, flaring, 2 point. Grunting, audible with stethoscope, it is 1 point. Audible with our own ears, it is 2 points. So there may be some questions to asking to calculate the Silverman score. Now, what is necrotizing enterocolitis? The main risk factor for necrotizing enterocolitis is a premature infant whose birth weight may be also less. Okay, there is usually abdominal distension, bloody NG tube aspirate, blood in stool. Okay, and the clinical changes coincide with the change from breast milk to formula or fortification of breast milk to high calorie density. Next day, you can see pneumatosis, in severe cases, portal venous gas or pneumoperitoneum. Pneumoperitoneum when there is a perforation. This is the portal venous gas. Just see a question. A 3-day-old preterm female neonate noted by the resident to have increased gastric residual volume and abdominal distension. On rectal exam, the stool is heme positive. Lactate is 2.9. So there is some shock. Supine X-ray of abdomen show air in the bowel wall but no free air in the peritoneum. That means there is no pneumoperitoneum or there is no perforation, but there is air in the bowel wall. That is called pneumatosis. What is the next best step in this condition? So this is a case of necrotizing enterocolitis. What is the next best step? Call surgical consult, start antibiotics, CT scan of abdomen, 0.9% normal saline, or renal lectide maintenance fluid. So it is necrotizing enterocolitis. You have to start antibiotics. The antibiotic choices vancomycin, gentamicin, and metrogyl. So you are covering anaerobic as well. So this is in adjunct with the abdominal X-ray to exclude perforation. So this was taken from a USMLE book. So calling a consult is always the wrong answer. Okay, you have to do something from your part because this is an emergency. You have to start antibiotics right away. This is another Bell scoring for necrotizing enterocolitis. You can remember it like stage 1. You have stage 2 and you have stage 3. Stage 2 and 3 are again classified into A and B. Okay. Now in stage 1, you are having apnea, bradycardia, temperature instability, but there is normal gas pattern, no pneumatosis or anything. GI findings, there can be stool occult blood positive with mild abdominal distension. For these, you can start antibiotics and you can do an NG tube aspiration with bowel rest. 2A means there is focal pneumatosis with hematochezia or fresh blood in per rectum and absent bowel sounds. Again, for that, you can start antibiotics and do bowel rest. In 2B, there is coming metabolic acidosis, there is thrombocytopenia, there is portal venous gas. So it is a little bit more severe abdominal tenderness with edema. Stage 3, again, there is oliguria. There is ascites, but no free air. Okay, there is still not perforation. There is abdominal wall edema, erythema, and induration. Stage 3B means there is shock, the vital signs are worsening, there is pneumoperitoneum, so there is bowel perforation, and there is an emergency. So the only absolute indication for operative management is this pneumoperitoneum, which is 3B. Relative indications again are abdominal wall erythema, edema, cellulitis, or radiographic evidence of portal venous gas, which is our 2B. Okay, or a persistent fixed loop or of a dilated bowel. The surgery you do is a transverse supraumbilical laparotomy with exploration of the intestine and colon. You remove all the necrotic bowel while salvaging all the healthy or questionable bowel. That is necrotizing enterocolitis, which is again a neonatal emergency. So this is in another way how you have classified the Bell scoring. So 1, 2, and 3. 1 is suspected, 2 is definite, 3 is advanced. Okay. So 1, there is temperature instability, apnea, bradycardia with gastric status, abdominal distension, but normal or mild ileus. You can keep the patient NPO, NG tube aspiration with antibiotics for 3 days. For definite diagnosis, where there is metabolic acidosis, thrombocytopenia, there can be pneumatosis, but abdominal cellulitis, but no ascites. Again, NPO antibiotics for 14 days. So if there is advanced case with respiratory acidosis, neutropenia, peritonitis, marked distension of abdomen, then you can go for, in severe cases, surgery. So perforation pneumoperitoneum is the absolute indication of surgery. Now there is something called hypoxic ischemic encephalopathy. So as the term hypoxia is a trigger. Okay, and there are stages for that. That is stage 1, 2, and 3. In stage 1, it is mainly tachycardia. The patient, infant is, the neonate is hyper alert and irritable. There is normal tone. There are no seizures. Okay, so that is the classical. There are no seizures, and EEG is also normal. And APGAR score is also um, a bit normal, 5 to 7. In stage 2, it is bradycardia is there. Okay, seizures are usually common, and there is an APGAR score of 3 to 4. In stage 3, the baby is completely flaccid. There are frequent seizures which are resistant to anticonvulsants. You just remember this. This can be, predisposing to a sequelae of chronic brain damage. Now, neonatal jaundice. What is Kramer index for neonatal jaundice? So it is the jaundice progresses from in a craniocaudal direction. So 1 means only the face, that is 5 mg per deciliter. When the upper trunk is involved, it is 10. If the lower trunk and thighs are involved, it's 12. If both the arms and lower legs are involved, it's 15. If palms and soles are involved, it is severe and it's more than 15. Okay, it's like a visual inspection. Check the naked baby in bright and preferably natural light. Examine also the sclera, gums, and blanched skin. Is useful across all skin tones. You don't just look; you just blanch the skin and look the underlying color. Yeah. Now coming to endocrinology, how do you diagnose DM in children? Again, the symptoms are polyuria, polydipsia, and weight loss. There can be hyperglycemia or 2 of the following on one occasion. That is fasting glucose more than 7 or 2-hour plasma glucose more than 11.1 in millimole per liter, or random glucose more than 11.1. Okay, or one of the following on 2 separate occasions. Fasting glucose more than 7, 2-hour glucose more than 11.1. Okay, so random glucose is not appropriate for confirmatory or second testing. You have to confirm it with fasting glucose or 2-hour plasma glucose. So DM1 usually in children is when there is higher risk for diabetic ketoacidosis. If diabetic ketoacidosis, you have to first manage ABC. Okay, stabilize the patient. You can give 100% oxygen. You can admit or monitor and correct the fluid losses. First thing to give in DK is not insulin, it is IV fluid, because they are in severe dehydration also. So give IV fluid, conduct an ECG to look for any abnormal T waves, as there can be potassium disturbances. You can administer and restore the glucose gradually. Okay, correct the electrolyte disturbances, identify or treat any precipitating events, usually like infections, and avoid any complications like cerebral edema. The low threshold to investigate like CT and MRI and treat DK. Cerebral edema is a major concern. Signs of neurological deterioration can include headache, bradycardia, irritability, decreased loss of consciousness, incontinence, and specific neurological signs. You can administer mannitol for cerebral edema. You can monitor the blood blood gas and fluid and electrolyte monitoring with the blood glucose. Okay, there are certain terms with the diabetes. Honeymoon phase is when there is good diabetic control on low dose of insulin, usually in the first 6 months after diagnosis, because there is an insulin reservoir in the pancreas, so that is acting. That is honeymoon phase. Now, brittle DM is where there is hypoglycemia and hyperglycemia, which is like an uncontrolled DM. So there is something called Somogyi phenomenon and Down's phenomenon. So you're giving insulin to the patient. So usually in the early morning, what you're seeing is there is hyperglycemia. In both Somogyi and Dawn, there is hyperglycemia. Somogyi is due to a rebound hyperglycemia. Like for example, you are giving high dose insulin to the patient. So around 3 a.m., what is happening is uh, there is a hypoglycemic event. So the body starts acting. So there are counter mechanisms happening inside the body which leads to hyperglycemia. So that is actually due to the high dose of insulin in the evening. What about Down's phenomenon? Down's phenomenon is hyperglycemia in the morning due to a low dose of insulin in the evening. Okay, so how do you differentiate? You can check a 3 a.m. level. If the 3 a.m. level is very low, it is the Somogyi effect. If 3 a.m. Level is normal or if it is higher, that is a Down's phenomenon. So Down's phenomenon, Somogyi phenomenon, and the normal the normal morning effect is increased growth hormone and decreased insulin level. But in Somogyi, there is a rebound hyperglycemia due to hypoglycemia throughout the night. So how do you differentiate? You can check the blood sugar in the middle of the night, like at 3 a.m. If there is high or normal, it indicates Dawn phenomenon. If it is low or hypoglycemia, it indicates Somogyi. Why do you have to differentiate? Because the treatment differs. In Down phenomenon, it is due to reduced insulin dose. So you have to increase the dose. Okay. For Somogyi phenomenon, it is due to higher dose. So you have to decrease the dose. So that is why you have to know this and you have to differentiate. So we'll come to parathormone. Uh, Parathyroid hormone is secreted from the parathyroid gland. It is situated behind the thyroid gland, which are four in number, superior and inferior parathyroid glands. And the normal effect of parathyroid on calcium and phosphate is to increase the calcium and decrease the phosphate in the blood. So it acts on bone and kidney to do this. So how do they do that? So for the parathyroid gland to produce parathormone, normally they need magnesium. Okay, so this is important. Some question can ask which the mineral is needed for parathormone. It is magnesium. Okay, so that is also it is one of the stimulant for the production of parathormone. So it is if there is hypomagnesemia or hypocalcemia, the parathormone will produce parathyroid hormone. It goes to the kidney and it increases the calcium and magnesium reabsorption and it decreases the phosphate reabsorption. So in effect, it increases calcium and decrease phosphate. Okay, and it also increased the vitamin D activation. That is 1 alpha hydroxylation of 25 hydroxy vitamin D to 125 hydroxy vitamin D, which is called the calcitriol, which is the active vitamin D. Okay, so we'll just see also how and how vitamin D is produced and how it is acting. So UV light and diet, that is the main two sources of cholecalciferol. It goes to liver and get hydroxylated at the 25 site, which is called 25 hydroxy vitamin D. The final step of activation is happening at the kidneys, which is 125 hydroxy cholecalciferol, which is called the calcitriol. Now, what is calcitriol doing? It is increasing calcium and phosphate. So that is the difference between parathormone and vitamin D. I just wanted to highlight this. Okay, so what vitamin D does is it increase calcium, also increase phosphate. But what parathormone do is it increases calcium, but it decreases phosphate. Okay, so in GI, vitamin D increases calcium and phosphate absorption. In kidney, it decreases calcium excretion, and in bone, it increases calcium and phosphate release. This Okay, there is increased osteoclast activity and there is increased calcium and phosphate release. The parathormone also increase the osteoclast activity. So net effect for the for the vitamin D is increased calcium and increased phosphate in case of vitamin D. But parathormone, what it does is increased calcium and decreased phosphate. Okay, and parathormone can increase the vitamin D concentration also. So these things can act as a negative feedback also. You know what happens in when there is high calcium? So high calcium, the initial investigation should be parathormone. So you can identify if it is a primary hyperparathyroidism or not. So if it is raised PTH, okay, it can be primary hyperparathyroidism, which can be like a solitary adenoma or hyperplasia or carcinoma or in MEN1 and MEN2 syndromes. Tertiary hyperparathyroidism, it is increased PTH after prolonged secondary when there is no no control from the higher centers. The parathyroid is on its own, so it keeps on producing parathormone and increasing calcium. There is something called familial hypocalciuric hypercalcemia. It is all in the name. Hypocalciuria means in the urine there is decreased calcium excretion, so there is increased calcium in the blood. It is mainly by the calcium receptor gene defect. Drugs like lithium can also uh, raise calcium. Now, if there is high calcium with low PTH, you have to then look for phosphate. If there is low phosphate, it is mainly due to raised parathormone related peptide, and that is mainly seen in squamous cell carcinoma. Squamous cell carcinoma of lung. Squamous cell carcinoma. Lung cancer, which type of lung cancer? It is squamous cell carcinoma, which can, because as a paraneoplastic syndrome, it can produce parathormone related peptide and increase the calcium with decrease in phosphate. Now, if there is increase in phosphate, it is usually vitamin D related, because I told vitamin D increases both calcium and phosphate. So you have to look for vitamin D. If there is vitamin D increase, then it can be granulomatous diseases like tuberculosis, sarcoid, lymphoma, okay, which causes extrarenal production of calcitriol by macrophages in the lung and lymph nodes, or due to excessive calcitriol intake. Now, if there is raised calcidiol, which is 25-hydroxyvitamin D, it is hypervitaminosis due to excessive intake of vitamin D or its metabolites. Now, if the vitamin D is low or like low vitamin D metabolites, it can be malignancy, high bone turnover, immobilization, milk alkali syndrome, drugs like theophylline, thiazide diuretics, estrogen, tamoxifen, etc. The symptoms and signs of hypercalcemia includes bond stones, groans, and psychiatric overtones. What does it mean? It can lead to bond pain, it can lead to formation of renal stones, there can be groans, that is abdominal pain, mainly due to this stone and all, and psychiatric disturbances, mainly confusion. So how do you manage it? The first thing is to hydrate. Hydration is the first step for management of hypercalcemia. Okay, hydration. The most common cause of hypercalcemia in a hospital is malignancy associated hypercalcemia, usually occur in the later stage of the disease. Most commonly in the lung cancer, we told squamous cell carcinoma as a paraneoplastic syndrome, renal, breast, ovarian, squamous tumors, etc. The creation of PTHRP, which is parathormone related peptide, which can uh, mimic the PTH action. Okay, in multiple myeloma, it is by cytokines. Lymphoma, it is by production of calcitriol. And osteolytic bone metastasis have a direct effect. Excess PTH is seen in parathyroid cancer, mainly related with MEN syndrome also. Acute management of hypercalcemia or hypercalcemic crisis is volume expansion. You have to give IV fluids. Then you can give a calcitonin, but it is a transient and a partial response. Bisphosphonate is actually the treatment of choice. Corticosteroid, it is most useful in vitamin D toxicity or granulomatous diseases like TB, sarcoid and all. Saline diuresis plus loop diuretic for volume overload, which can act as a temporary measure. So first thing is to hydrate. Now if there is a low calcium, what are the investigations? First you look for PTH, you look for phosphate, you look for magnesium, you look for urinary calcium, and you look for creatinine. Okay. Now if there is a raised PTH or no, a low PTH, what is the differentials? If there is low PTH, it is hypoparathyroidism. So parathyroid gland destruction by primary hypoparathyroidism, which can be autoimmune, okay, or infiltrative disease or HIV or idiopathic. Iatrogenic, mainly by iodine ablation, post-thyroidectomy, okay, or post-surgical correction of primary hyperparathyroidism. Also, you can get low calcium. Liver dysfunction, like in hemochromatosis, you can have low PTH and low calcium. Low magnesium, like in chronic alcoholism, the main electrolyte abnormality is hypomagnesemia, okay? Or in drugs with antineoplastic agents, also low magnesium, because magnesium is also important for parathormone production, okay? Now, if there is low calcium with raised PTH, it can be you can differentiate based on phosphate. If it is low phosphate, it is vitamin D related, because low calcium, low phosphate, it is vitamin D, because vitamin D acts in the same direction. So vitamin D, if there is excess, there is high calcium, high phosphate. If it is low, there is low calcium, low phosphate. So now if there is a decrease in calcitriol, it can be a chronic renal failure or a vitamin D dependent rickets. Okay, if there is a decrease in calcidiol, it may be due to decrease in intake or malabsorption, like in celiac disease or IBD. Or nephrotic syndrome, where this vitamin D binding protein is lost, or drugs like phenytoin, carbamazepine and all. Or if there is increase in calcitriol, it's a vitamin D resistant rickets. So vitamin D is not active. Or secondary hyperparathyroidism. Or if the PTH is raised with low normal phosphate, that is called pseudo hypoparathyroidism. That is mainly due to the PTH resistance secondary to the G protein deficiency, or can be seen in acute pancreatitis also. Okay, this is the workup of low calcium. You have to first check for the parathormone to see for if it is primary hypoparathyroidism or not. If it is the parathormone is raised, look for vitamin D and also phosphate. What are the signs and symptoms of acute hypocalcemia? Paresthesias, like perioral, hands and feet. There can be numbness. Shostak sign means mainly after thyroid surgery, you have to manage, immediately look for these signs, especially within the first 24 hours if there is severe hypocalcemia. So what is Shostak? You are percussing on the facial nerve just anterior to the external auditory meatus. That elicits an ipsilateral spasm of the orbicularis oculi muscle. That is called Shostak sign. What is Strossio sign? When you are inflating the blood pressure cuff above the systolic pressure for 3 minutes, it can elicit carpal spasm, carpopedal spasm. Carpal spasm means of the hands, pedal means of the leg. So carpal spasm and paresthesia, that's Strossio sign. See, these are the signs of rickets and osteomalacia. Or rickets is in a growing child and osteomalacia is in an adult. These are the 10 important clinical features of rickets. There are wide sutures, delayed closure of fontanelles, frontal bossing, craniotabes or a soft skull bone, rachitic rosary, that is beading of the ribs, dental hypoplasia, also delayed eruption of teeth, pectus carinatum, swelling in the wrist and ankle joint, Harrison sulcus, that is in the Harrison sulcus, and bowing of the legs. Main X-ray finding is the widening of epiphyseal plate. This is the first and specific sign of rickets. You can when you are suspecting rickets, always look for an X-ray wrist, and you can see the widening of epiphyseal plate. Other signs are cupping and white line of Frankel. White line of Frankel is the calcification which is during the healing. So this is called fraying, this is called cupping. Okay, fraying means like this, irregular. Cupping means like this. Okay, so that is called fraying and cupping of the metaphysis. Widening of the epiphyseal plate is the first and specific sign. X-ray changes in healed ricket will be a line of calcification. Okay, coming to hypo and hyperthyroidism. Hypothyroidism, some of the clinical features are microglossia. There can be prolonged jaundice, feeding difficulty, lethargy, constipation. There can be umbilical hernia, large fontanelle, puffy face, and swollen eyes. Hyperthyroidism, there can be a triangular facies with low birth weight, IUGR, microcephaly, premature birth, tachycardia, irritability, frontal bossing, triangular facies, hepatosplenomegaly. There is goiter. So coming to disorders of sexual development. So we are talking about hermaphrodite. Hermaphrodite means one who is having both female and male sexual external genitalia or internal genitalia. So 46XY with the disorder of sexual development. 46XY is a male, but how do they become have like a female? Like they may not have an external genitalia. So that may be due to a 5-alpha reductase deficiency. So that is testosterone to dihydrotestosterone conversion, which is the active form of testosterone, or there can be an androgen receptor deficiency or insensitivity. So they are born as a male genotypically, but they may be grown up as a female. So only when they are not hitting puberty or having menses, they may be worked up, and genotype will show XY. Okay, or LH or HCG unresponsiveness, or there can be an inborn error of testosterone biosynthesis or Leydig cell hypoplasia. Leydig cell, which is the one which is producing testosterone. Now, if it is a genotypical female, they can be like a male appearance due to virilizing congenital adrenal hypertrophy or hyperplasia, or a maternal source of virilizing ovarian or adrenal tumors, or untreated maternal CH, or placental aromatase deficiency. Aromatase is the one which is converting androgens to estrogen. Okay. Now there is an ovotesticular variety which is a true hermaphrodite. They are having both ovarian follicles and seminiferous tubules in the same patient, but they'll have a 46XX karyotype. They have a mixed gonadal dysgenesis. The coming slide. So what is a male pseudo hermaphrodite? So their genetic makeup is XY. So they are called male. Why pseudo hermaphrodite? Hermaphrodite is one who is having both female and male sex organs. What is a pseudo hermaphrodite? They have small phallus, hypospadias, and undescended testicles. So more like a their genetic makeup is male, but they have a small phallus and hypospadias, which may not look like a male external genitalia. Now, female pseudohermaphrodite genetic makeup will be XX, so they are female, but there is clitoral hypertrophy and labioscrotal fusion, which may seem like a male external genitalia. Okay. One thing you have to not by heart the whole cycle. You just have to know that everything is made from the cholesterol, like your mineralocorticoid, glucocorticoid, and sex corticoid, which are your adrenal cortical hormones, which is stimulated by the ACTH from the pituitary, and it secretes mineralocorticoid, glucocorticoid, and sex corticoid. That is zona glomerulosa, zona fasciculata, and zona reticularis. Okay, so these are the three things. So mainly from the cholesterol, the different enzymes that you have to remember is your 21 hydroxylase. So 21 hydroxylase is important for mineralocorticoid and glucocorticoid. So if there is 21 hydroxylase deficiency, if one of the, suppose if this is blocked, what happens? Then everything will go to either this or this. Okay, that is how it is functioning. Okay, now if you are having 21 hydroxylase deficiency, you can't produce mineralocorticoid and you can't produce glucocorticoid. So everything will go, the precursors will accumulate, like progesterone will accumulate and will go to formation of sex steroid. So androgens will be more. So that is in short what is happening. So you have to know that 21 hydroxylase is important for mineralocorticoid and glucocorticoid. So is 11 beta hydroxylase. But the major hormone which is deficient is mainly 21 hydroxylase. Okay. Then something that can be deficient is 5-alpha reductase, which is important for conversion of testosterone to dihydrotestosterone, which is more like an active form. Okay. Then you can have a 17-alpha hydroxylase deficiency. Okay, or so 11, 21 is more or less similar because they are both involved in mineralocorticoid or aldosterone and glucocorticoid or cortisol formation. So in that, androgens will be more. Okay, and there can be virilization. Virilization means more like a the female can be more like a male. That is called virilization. Okay. Then if there is 17-alpha hydroxylase deficiency, they may not form 17-hydroxyprogesterone, or furthermore they cannot produce steroid also, but they can produce aldosterone, and aldosterone will have some mineralocorticoid, mainly mineralocorticoid activity, but it can have some glucocorticoid activity also. So in 17-hydroxylase deficiency, the major defect is deficiency of sex steroids. So these are the four hormones: 11 hydroxylase, 21 hydroxylase, 17 hydroxylase, and 5-alpha reductase. And coming to congenital adrenal hypertrophy, main responsible hormones is 21 hydroxylase, which is responsible for around 90 to 95% of cases. So it results in decrease in cortisol and aldosterone. I hope you have understood how it is decreasing, because that is one enzyme which is very important in the step of formation of cortisol and aldosterone. So they shunt towards increase in androgen production. Okay, cortisol deficiency will lead to elevated ACTH because the negative feedback is gone. So that will lead to adrenal hyperplasia. The rarer causes include 11 hydroxylase deficiency, cholesterol desmolase deficiency, 17 hydroxylase deficiency, etc. So congenital adrenal hyperplasia, it's autosomal recessive. It is disorders of steroidogenesis due to deficient enzymes. The buildup of hormones proximal to the deficient enzyme, ACTH and androgens. There is it's, classified into classic or severe form and non-classic or mild form. So in the adrenal cortex, zona glomerulosa is mainly producing mineralocorticoid, which is the aldosterone. Fasciculator is producing glucocorticoids or cortisol. And zona reticularis is mainly forming the sex steroids. So newborn screening for classic CAH can be due to 21 hydroxylase deficiency. So you can assess for that. Also assess for 17 hydroxy levels. The types of CAH is classic deficiency with salt wasting and without salt wasting, or simple virilization. With salt wasting means inadequate aldosterone, which results in failure to thrive. With aldosterone normally what it does is it increases sodium, decreases potassium. So if there is the inadequate aldosterone, there can be hyperkalemia, hyponatremia, hypoglycemia, and acidosis. This is the majority of classic CAH types. Classic deficiency without salt wasting, that is a simple virilization with adequate aldosterone levels. The females typically present with amenorrhea, precocious puberty, polycystic ovaries, and hirsutism. Males can present at birth, they may show hyperpigmentation from overproduction of MSH, because ACTH can have MSH-like activity, so there can be hyperpigmentation. Penile enlargement, rapid growth, and accelerated skeletal maturation. They may present with virilization later in life. Then there is non-classic CAH, which is mild androgen excess. It is sometimes asymptomatic. There can be virilization present later in life. So again, I've added this slide. 21-hydroxylase is important in aldosterone and cortisol production. So is your 17, sorry, 11-hydroxylase. Okay, 17 is mainly in the sex steroid. 5-alpha reductase in testosterone 2, dihydrotestosterone production. 21, 11, and 17 is the deficiency in enzyme. In one pathway, cause precursors to be shunted over to the remaining functional pathways. So what happens in 21-hydroxylase? There is decrease in cortisol and aldosterone with increase in androgens. Okay, so what happens? So aldosterone is low, so there is loss of sodium and gain of potassium, and there is hypotension because loss of sodium and water leads to hypotension. There is salt wasting with hypotension. So ambiguous female genitalia with male precocious puberty because there is increase in sex hormones. Now 11-hydroxylase deficiency, there is the increase in deoxycorticosterone, which has a weak mineralocorticoid effect, which is a weak version of aldosterone. So there is actually hypertension. Okay, salt wasting is 21-hydroxylase deficiency. That is the more common form. It is a salt wasting variety. Here, 11-hydroxylase, there is increase in deoxycorticosterone, so there is hypertension. And due to excess androgens, there is ambiguous female genitalia. 17-hydroxylase deficiency. What happens in males? It will be born with either feminized or completely female external genitalia because sex hormones cannot be produced. So completely female external genitalia. And there can be hypertension from salt and water retention because sex hormones are not produced. The cycle will be shunted to producing more aldosterone. So there is loss of potassium with gain of sodium and water. So there is also hypertension. Hypertension is seen in 21-hydroxylase deficiency. Okay, 17-hydroxylase deficiency in females. What does it do? Sex hormones are low. So female genitalia appears sexually normal at birth because female genitalia doesn't need sex hormones. This androgens is not needed. But androgens are essential to puberty. So the females will present with a lack of secondary sexual developments like absence of breast development, pubic and underarm hair. So the lack of secondary sexual characters. So 21-hydroxylase deficiency, the most common form. So there is aldosterone is low, there is cortisol is low, but sex hormones are high. Since aldosterone is low, there is salt wasting or there is hypertension. The girls will be virilized, but boys will be normal because sex hormones are increased. Electrolyte abnormality, there will be hyponatremia, hyperkalemia, and hypochloremia. 11-beta hydroxylase, again, the aldosterone will be low, cortisol will be low, sex hormones will be high, but 11-deoxy corticosteroid that will be there, so that there is hypertension. This girls will be virilized due to sex hormones, boys will be normal, but there is less severe electrolyte abnormality. The severe form is 21-hydroxylase, and that is also the common form. 17-hydroxylase, there is decrease in sex hormone levels and cortisol levels, but there is increase in aldosterone, so there is hypertension and hypokalemia. Girls will be normal because there is no increase in sex hormones, but boys will be there is pseudohermaphroditism, more like a female genitalia because there is no and coming to puberty. In what females, the usual sequence is stellarch, so there is first breast budding, then pubarch, where there is axillary hair, body hair, and mild acne. Then there is a growth spurt, then menarche. Mean age is 12.5. So that indicates that the growth spurt is almost complete. Menses may be irregular in duration and length of cycle during the early period. Early puberty is common in females and is often constitutional, but late puberty is rare. That is when you have to mainly work up. But in males, early puberty is uncommon. when early puberty is there, then you have to rule out any organic cause. Late puberty is common and often constitutional. That is the difference. In males, it is usually the testis first, then penile enlargement, then pubarch, then growth spurt. Okay, growth spurt occur later in boys. So in females, it is thelarch, pubarch, growth spurt, and menarche. In males, it is testicular enlargement, penile enlargement, pubarch, and growth spurt. So girls, breast buds, pubic hair, growth spurt, and menarche. In males, it is testicles, gonadarch, then the penile enlargement, then pubic hair, then adrenarche or axillary facial hair and voice changes, and growth spurt. Okay, in girls, usually the late puberty is a problem. So that is when you have to mainly work up. In boys, precocious puberty is mainly a problem. That is when you have to mainly work up. The age is 8 to 13 years. Okay. Delayed puberty for males, it is a lack of testicular enlargement by 14 years of old. For females, it is lack of breast development by 13 years or absence of menarche by 16 years or within the first 5 years of pubertal onset. What is an androgen insensitivity syndrome? Androgen insensitivity means actually genotypically it is a male 46XY, but they have a female appearance. They may have been grown up as a female, but they are not hitting puberty, or they are not having menses, so they are being worked up. During the workup you will see that the genotype is 46XY, and they may have an undescended testis, cryptorchid, or testis. They'll have breast development, but they'll have no pubic hair. No, they may have a cryptorchid testis. So androgen insensitivity means there is androgen, but there is mutation of androgen receptor, so it cannot actually act. So that is why they're not becoming like a male. Okay, this is for the familial versus constitutional short stature. In familial short stature, both uh, sexes will be equally affected, but constitutional is more common in boys. Okay, in the constitutional short stature, the history will be of delayed puberty. In familial, it will be of short stature itself. Okay, the height velocity will be normal in both, but puberty will be delayed in constitutional, right? The born age will be less than chronological age in constitutional short stature, but will be normal in familial short stature. So that means the final height will be short, but they are normal for the target mid-parental height. But constitutional, the final height will be normal. They are just slow. Okay, so their puberty is delayed, their born age is less than chronological age, but they are finally hitting the actual final height, normal final height. But familial means the velocity is normal, but their target height is less. So this is the target height. For girls, it is father's height plus mother's height minus 13 by 2. For boys, it is father's height plus mother's height plus 13 by 2. Normal range can vary within 10 centimeter. Okay, again, if there is a short stature, you look for upper to lower segment ratio. It can be increased in achondroplasia, short limb syndromes, decreased in Marfan's and Klinefelter. So decreased means upper segment by lower segment, decreased means lower segment will be more, like in Marfan, Klinefelter, Kalman. Okay. Upper segment is from the top of head to pubic symphysis, lower segment from pubic symphysis to the floor. Obesity is when overweight, BMI more than 85th percentile. Overweight is BMI more than 85th, obesity is BMI more than 95th for the age and height. Okay, that's all for today. We'll discuss the rest of the